How much should we blame the obesity epidemic, health ailments, controllable lifestyle factors to contributing to the pandemic? Everything going on in the world right now with the virus. So basically, I need to take some responsibility here because in light of data and information particularly from Kevin Bass, who has illuminated a idea that I was more misguided on. And so I'm going to show you an example of how that was so. So I made a post on my Instagram about August 16th, and I talked about how, man, if we addressed all these population health and well-being controllable factors, if we mitigated systemic depression, obesity, diabetes, nutrient deficiencies, etc., what could this look like? What could this situation look like? What, instead of band-aid solution, we're looking at root causes? What if 95% of the population were healthy? Maybe we need to point the finger at ourselves here. Maybe we're at fault here, guys. So, and then at the end, I'm like, let's support each other to empower each other towards better health. And while this is altruistic, well-intentioned, I was misguided. It is misguided in light of the evidence of the control on the risk factors and risk towards a lot of these controllable lifestyle changes. So look, got a lot of social credit for this one. A lot of people coming around and like, yeah, it feels good. This is dangerous because if the idea is misguided or is there some error in the lines of thinking, you're just not up to date on the evidence, like clearly I wasn't, it makes common sense, right? Reduce obesity, reduce risk of disease, right? Yeah, it's right. But there's nuance there, and there's actually an amount of relative risk that needs to be added to this conversation that may dramatically overestimate some of the risk associated with these conditions. So we're going to talk about that right now. I just want to put my hand up and say, I do not mean to contribute to misinformation in any way. That's why I'm going to come on here and say, hey guys, here's how I may have been a little bit misguided, well-intentioned, but let's clear up some of the evidence. Credit to Kevin Bass, who's an amazing person to follow, I think, on challenging your preconceived ideas and notions. So let's all agree at least that, yeah, these things I mentioned, they're going to have some level of impact on improving, obviously, health status. That's significant. And all types of diseases, all-cause mortality, quality of life, cognitive function, etc. But the conversation is, does improving these things improve the outcomes of COVID-19, SARS-CoV-2 disease? Well, it depends. It's not as simple as the common sense idea that mitigate obesity, improve disease outcome. There is some relative risk, and it depends on the classification of some of these factors. So why this is so important, I think Kevin makes a note of that. Obesity, we look at the kind of the data behind this of a 17 million people report that obesity is claimed to be like the real cause of COVID-19, and I was claiming a lot of these factors are a significant impact, and I wasn't doing it in a real direct way, but a bit more of an indirect way of, be the change. I value heavily self-independence and taking action as an individual to improve the outcomes of our livelihoods and population at large. That's where I bias. Now, that line of thinking can get you into not being entirely accurate, okay? So Kevin believes this is overstated because, and a lot of health influencers, you could health professionals coming along and potentially exploiting this idea to build market share and build clientele and trust and rapport. And by misguided thinking, that is well-intentioned for most people, but obesity may not be, and overweight and obesity may not be the real problem here. And that may be such a, on face value, such a, what? What do you mean? Well, let's dive into it. So here we have an August 2020 study. So really, we could have had this conversation a year ago. It was a study of 17 million people. Okay, now this was a UK. Now it's not a randomized controlled trial here, guys. That's not possible for such a large sample. So can we calm down there on expecting randomized controlled trials, which so many people, please? It was the primary care records. They were pseudonymously linked to 17 million primary care records, pseudonymously linked to 10 million COVID-19 related deaths. So pseudonymously means it's under fictitious names, and they made a link based on medical records. So here's what we found. Let's go down. Let's just see what are the major risk factors here that could contribute to death, SARS-CoV-2 death, okay? Because there was an article by the CDC. Here it is. CDC study finds 78% of people hospitalized for COVID were overweight or obese. Now, the study I'm about to show you, that is about death as an outcome. This is about hospitalization. Okay, but it's relevant when I talk about it. It's not a direct link, but it is relevant. And unfortunately, I almost never read the articles, and I almost recommend never read the news articles. Click the link to the actual study and read the report, because with all due respect, the majority of journalists do not understand basic statistics and research methods and how to interpret data. So just exercise some caution there. Unfortunately, but not unexpectedly, they did not link the study to my observation. So, what are some actual major risk factors to SARS-CoV-2 that we should be aware of? Okay, one major unavoidable risk factor is age. Okay, so fully adjusted means, so we're going to look at this right column, fully adjusted for a 95% confidence interval. I'll explain what that is for those who don't know in a second. Fully adjusted means we've adjusted for all the other covariates, all the other covariables such as ethnicity, age, sex, are the major ones. You'll have to read the study to see all of them, okay? So after adjusting for some of these variables, here is the risk ratio, relative risk ratio. So compared to, and this is important, let me explain this. The 1.00 is the reference. It's what we compare to. You always need a reference range when you compare between groups. So if you are between 18 and under 40, 18 to 40, and I've highlighted here so it's easy to read, that is a reduced risk of death of COVID-19. How much? Well, dramatic. We're looking at a 96% reduced risk, okay? So what you want to do is you want to make up the difference between that number and number one, and the one to figure out the reduced risk. And then in between the bracket here, you have a confidence interval. That is the range. Nothing is specific 100% set. There is a range like that a population will get it. So about a 90, so 0.4 would make it, sorry, that's 96% to 92%, sorry, 98% reduction in odds of death, okay? Excuse me if I'm reading them a bit wrong. Anyway, and you see being 40 to under 50 category, we see a 70% reduction in risk compared to being 50 to 60. And then compared to being 50 and 60, we see age being significantly associated with all the way up to 20.6, which is a 2,060% increased risk of death if you are 80 years old plus, compared to being 50 to 60. Can't do anything about that. Everyone's going to age. That's a major, major significant risk factor associated. So age is a major risk factor, okay? And we can see a nice little graph here. I'll put the links below. Nice little graph here that you can go to. It's the economist.com graphic detail COVID pandemic mortality risk estimator. So for males, we can see the hospitalization rate and death rate increase as age increases pretty significantly. You go to female, and females are in the fortunate basket where they're at a considerably lower relative risk for COVID-related outcomes, which is great for females. And we think maybe this is due to some having more ACE2 receptors or ACE2 receptor binding capabilities. But that's a conversation for another video. You can look that up. Now, speaking of sex, that's a major significant risk factor, with males being 59% more at greater risk of COVID-related death compared to females. Okay, damn. Can't do anything about that either. Now, controllable lifestyle risk factors. Let's get to the obesity, overweight epidemic conversation argument. BMI. Yes, it's BMI. It's not great for populations like myself who have a high portion of relative muscle mass, but this does not represent the majority of the population. Majority of the population ain't weight training, doesn't have considerable muscle mass, so it can be useful on a population basis for the average person. Thus, these are still credible. So, I'm done posts on this about BMI. I'm criticizing it, so I just need to explain my bias is objectivity. Can that be my bias? Anyway, BMI, look at this. Reference range is not obese. BMI, okay. What's up with that? You can be overweight, but only have a 0.05 risk factor? In fact, it's 1 to 1.11, which is a 0 to 11% increase in relative risk, which is pretty low. And very low, actually. And probably doesn't warrant a lot of the arguments that a lot of health enthusiasts, influencers, or health professionals and coaches like myself potentially have made or make and will make. Now, it's not to justify obesity and being overweight is a good thing, but it's to put, because this is classified as class 1 obesity. If you put up a BMI chart, you'll see that this represents a large proportion of overweight people and obese people, okay? It's pretty low. Huh. Guess we overestimated and overstated that, didn't we? On next classification, class 2 is a 40% increase in relative risk. That's more significant now. Now, class 2 and class 3 obesity, okay? I'll pull up a BMI chart in a second. I'll show you what that actually practically means. Come over here. And we can start to see green is healthy, overweight and yellow. This orange and red, that's really what we're talking about here. Where we start to see people who are, let's say you're 6 feet in height, or I'll give you the average height, 5'11" in height, but you are, 180 pounds, 185 pounds. I'll do kilograms for my people. 97 kilos, 95 kilos, okay? That's now giving you some idea of if you're an average person with that much fat mass, okay? Now we're starting to see some more significant effects. And we have to go all the way to class 3 being extremely obese has a 92% increase. However, age has even being 70 to 80 has a 600 to 700% increase. Still has a significant higher increase in risk compared to being overweight. And we'll talk about why this is important later. Oddly, and smoking was lower. Current smokers, I'm almost like, what? But then, don't worry, in their study, they clarify this is not because smoking potentially could have some protective mechanism, because you might be look at that. So that's 11% decreased risk. You can see here in the study, if you want to read more, we further explored that the smoking effects were therefore fitted a model adjusted for demographic factors, which showed that non-significant positive hazard ratios for current smokers which crossed 1, which makes, if a hazard ratio crosses 1, it makes it insignificant, and it's just as likely that it caused it to not cause it. So you have to look, when you look at hazard ratios, which is a relative amount of risk of something occurring compared to something else, if it crosses 1.0, if for example 0.9 over 1 to 1.18, we cannot confidently say to a 95% efficacy that this caused this, okay? This does not postulate protective effects of nicotine. Let's just clarify that before people start smoking. You think it's going to protect them from COVID-19 death. Let's just summarize. Ethnicity, mixed, South Asian, black, and other, increased risk from 30 to 45 to 48%. Blood pressure had I put it in yellow because like it's not a good thing to have increased blood pressure, but increased blood pressure seems to be in that middle ground where it doesn't seem to be protective. Well, it doesn't seem to have a significant impact either way. Diabetes does, though, 95% increase approximately. Including by measured with a HbA1c, which is a 3-month marker of your blood glucose levels measured through your red blood cells. So we see, yep, that's another risk factor. Reduced kidney function, major risk factor, around 250%. That is definitely want to look at glomerular filtration rate as a proxy for kidney damage, and organ transplant, and which you may think is not really relevant to you individually, but is actually common. Well, not common, relatively common, but there are many people out there who need to consider now their relative risk profile. If you've had an organ transplant or autoimmune issues, okay, that changes your risk profile now. Should I get the vaccine or not? Well, probably don't want a 350% increased risk of death because of that. So that's a factor. So the summary from this, and Kevin made a nice little Twitter summary of this research: being male, 59% increase; mild obesity, 5% more increase; morbid obesity, 92% increase; being 80 plus, up to 2,060% relative risk increase; being unvaccinated, 2,500+% increase. I don't have the exact citation on that, though. Kevin's, though, a very reliable source. I do have a citation, though, on breakthrough cases that he may have got it from. And so the fact of the matter appears to be that we are misappropriating controllable lifestyle risk factors like obesity and being overweight, and overestimating their effects on protecting us or protecting people from a COVID-related death. It's not to say this isn't significant or doesn't contribute. Okay, that's a straw man argument. And not to say it doesn't contribute. We're saying a virus is systemic. It affects and damages rapidly. Health is idiosyncratic. It just affects the individual mostly. Yes, you can influence others, but it's largely idiosyncratic to you, and if you're a mother, to your child, okay? It takes a long time to change. Therefore, fixing obesity and health epidemic is not the most significant answer acutely. Long-term for sure. But right now, we're going to get a small to moderate margin of improving COVID-related outcomes. Awesome. But when you work with people who have suffering from health ailments, it takes time. You're unraveling complex, multi-year destructive habits. This is what I do, okay? It's particularly on a population level, a slow-moving target. Therefore, maybe not where we should probably spend most of our time right now. It adds up, but is it the lowest hanging fruit? Probably not. Now, this is now a justification for vaccination. This is where this conversation leads to. Okay, controllable lifestyle risk factors. Yep, some small to moderate effect size, but really the most significant effect size to improving your resistance to a virus, particularly this one, appears to be the vaccine in maximizing protection and mitigating hospitalization, long-term side effects, and morbidity. And so that's basically what we come to at the end of this summary analysis. And I just need to put my hand up and say, guys, I believe we should still take personal responsibility for our own health. Abso-fucking-lutely, I will keep preaching this message. However, it's overestimated according to this 17 million pieces of data from participants and people who have in the UK who have experienced COVID-related issues. And so obesity, should we blame the pandemic on obesity and poor health? Probably not. Probably not. Does it impact? Yes. But does this relative amount of impact appear to be significant, particularly compared to vaccines? It doesn't seem so. Do with that what you will. Thank you, Kevin Bass, for illuminating this information. Try not to get too emotional. It's just information. It's just data. No emotion here. Just analyzing, observing, summarizing, and documenting. Thanks, guys. See you in the next one.